This episode of Job Shadowing HE is kindly sponsored by Gayton B. Sanderson, the UK's leadership expert across public services, not-for-profit and education. Partnering with universities to navigate change and build stronger, more inclusive leadership teams, Gayton B. Sanderson has deep expertise in executive search, interim leadership and leadership development. Through executive search and interim leadership services, they identify and place HE leaders who reflect the communities they serve and who can drive success as the higher education landscape evolves. Through leadership development and talent consultancy services, they work closely with you to develop leaders who can deliver lasting impacts in inclusivity, collaboration and performance. Whether you're looking for your next Vice-Chancellor or seeking to recruit and develop your senior leaders, choose the experts who are known for delivering diverse shortlists, long-lasting leadership interventions and world-class client and candidate service. I'm Susanna Marsden, a higher education consultant who helps to develop and support HE institutions in the UK and beyond. This podcast takes a deep dive into the roles of people who work in this hugely varied higher education sector. Each episode reveals what's involved in a specific role, the career path that led to it, and tips on how to get in and get on in these jobs. My guest in this episode is Dr. Alex Street, Senior Research Fellow at the Cambridge Institute for Music Therapy Research, part of Anglia Ruskin University. Alex is an applied researcher who specialises in the use of music therapy for patients undergoing neurorehabilitation following stroke and brain injury. In this episode, he shares more about how music therapy works, including case studies of patient benefit. We also explore what led him to train as a music therapist, as well as progressing his career into research, and we hear more about what it's like to be a senior research fellow in his field and more broadly in HE. Alex, welcome to the podcast and thanks for being my guest in this episode. You're Senior Research Fellow in Music Therapy at Anglia Ruskin University. And for people who are less familiar with the music therapy discipline, can you share a bit more about its purpose and scope?
I can, yes, thank you. I'm glad to be here. Music therapy offers a non-verbal way of communicating with any age, any diagnosis, and it operates via the various components of music, rhythm, melody, harmony, timbre, and all of those things. And it's quite widely practiced from a psychodynamic perspective, where it's the therapeutic relationship that's at the centre. So it can be quite similar in the way that it functions with psychoanalysis. We're playing music with our patients or clients, and we're responding to their playing. They don't have to know how to play an instrument. And by the way that we learn to respond to all sorts of different people, they understand that they're being responded to with empathy, and they're being listened to and understood. And then we can develop a complex musical dialogue. And then for the verbal clients, those that do have access to language, they start talking about themselves through the music that they've played. For example, sometimes I don't feel listened to, but here in this situation I do. I can tell by the way you're playing. And then they'll talk about their relationships and how they function in work and in the world. And we can start addressing the things that they'd like to change. There are other ways of using music therapeutically as well, where the relationship with the therapist is important in the same way that it is perhaps with a physiotherapist or an occupational therapist, but we're trying to use music in other ways to help them. So we might be using singing and different ways of rehearsing singing, like you might do in a choir, to help people to articulate more clearly or to help them find words. Or we might be using musical instruments in ways that help people to reacquire music and be able to concentrate and focus their attention on particular things.
And you're part of ARU's Cambridge Institute for Music Therapy Research, a world-class interdisciplinary research institute dedicated to advancing the understanding of music therapy and its positive impact on health and well-being. Can you share some examples of some of the research work going on?
Yes, we have different work streams. There's healthy aging and dementia, music therapy and neuroscience, and we have neurorehabilitation and stroke, which is my area, and then there's mental health and children and young people. The research ranges from, at the moment we have Autism Chime, which is a project running in partnership with Cambridge University, and we've had a range of dementia projects, including Radio Me, which was a collaboration with Plymouth and Glasgow University, and that was a big project. It was about a £2.3 million project funded by the Engineering and Physical Sciences Research Council. And we worked with people with dementia and their caregivers. We recruited about 50 dyads, and myself and another researcher went out and saw these people in their homes over a number of weeks, compiling playlists and listening to them, with them, and looking at their heart rate and how that varied, and interviewing them about them, and using some questionnaires on mood and how the music, to try and establish how it may have an effect on mood and how quickly. And this was in order to build a system that would be called Radio Me, which was housed in a laptop, and it collected live heart rate data. And when the heart rate reached a point that was identified as a threshold for agitation onset, it would trigger their playlists, interrupting the live radio stream, and hopefully prevent any escalation into agitated behaviour. And the reason for that is that agitation is one of the primary reasons for care home admission in these populations. So it was to try and extend home living with the best possible quality of life. And another project more in my area, which is more to do with rehabilitation, is the EEG study that we just did, where we delivered 15 home-based upper limb, so arm and hand exercises for stroke hemiparesis. And that's not been done before, that intensity. And it's working towards aligning with the NICE guidelines that indicate 3 hours of rehab a day for arm rehabilitation is required. And we found that, the people with less hemiparesis responded better with their arm function. We did various arm tests that showed that they had actually improved. And we also found that the way people functioned cognitively improved as well. Those with the more severe hemiparesis that had less finger movement would have required more intensity over a longer period of time. And then the other projects in my work stream are, I have an online support group for musicians who've had a stroke. And that's been really interesting because they've described their journey, particularly the emotional impact it had on them, because it disrupted their relationship with music, and more specifically with their instrument or voice. And that's really traumatic, and it's really under-recognised and under-catered for within any stage of neurorehabilitation. And in specifically upper limb rehabilitation research using music, musicians are usually not included because they would skew the data. They may have, better sort of cortical representation than non-musicians. So I'd like to find out how many musicians there are who've had a stroke and their experience, and how many people who aren't musicians that have used music in some way to help. We run a clinic which is free for stroke survivors, so people have come so far from Cambridgeshire and Bedfordshire via NHS services and community groups, and we do all sorts of different exercises there, whether it's for attention and executive function or articulation, people with aphasia, or motor control, and it's been really good. And that provides a placement for our trainee music therapists, because we also train music therapists and drama therapists here as well.
I'm interested to know a bit more about your background and what got you into the music therapy profession. I know that you started your academic career with a degree in music at what was City University in London. which at the time combined university academic study with performance tuition at the Guildhall School of Music and Drama. Now, music degrees offer huge potential to go into any number of directions. So what was your motivation that took you into pursuing music therapy?
There was a 10 or 12 week module as part of my degree that I chose to do in music therapy, and I was really captivated by how music could be used, and I suppose it resonated with the way that I'd learned. I did have formal lessons and things like that, but I was also always much more interested in improvising and spontaneous music making, and one of the definitions I described earlier, where it's very much centered on the therapeutic relationship, operates via those mechanisms. So I found that really sort of liberating. The other thing that happened when I was training at City was I had a great guitar teacher at the Guildhall called Robert Brightmore, and one of the reasons I went to university was to try and improve my right hand technique. I felt that I'd become sort of stuck in how fluently I could play as a classical guitarist. And what he taught me was amazing. And I suddenly was playing faster and more fluently. And I was, it was quite sort of euphoric, really, the whole experience. And then over one Easter period, I was practicing so intensively, which I'd never done before. I'm talking sort of 4 or 5 hours a day, and enjoying it. That I started to feel this tension in my right hand. And I thought, I'll just play through it, it'll go away. And I thought, no, this doesn't seem right. And so I called Robert, and he said, stop playing straight away, don't play anymore. See me when we resume, the term. And it turned out to be something called musician's dystonia. And it also coincided with the publication of a book called The Musician's Hand. And Robert knew about this book, and he'd also had a previous student who developed this condition. And one of the authors was Ian Winspur, who died a couple of years ago. He was a hand surgeon who really advocated for musicians to use their instrument to rehabilitate after hand injury and surgery. And I went to see him, and he told me what it was, and he told me what to do, and I did it, and it took about 3 years. So I suppose I had a bit of insight, really, through that period, and it was really traumatic. It's something I think that resonates with what the musicians in the group that meets on a Monday every 3 weeks tell me about their experience as well. And I learned something about the neural mechanisms of movement as well. So that was another thing that happened probably shortly after doing that module.
And to train as a music therapist requires formal master's level training, which is accredited by the Health and Care Professions Council. And you undertook your 2-year training at the Guildhall School of Music and Drama following your undergraduate degree. What did the first phase of your professional career look like after qualifying?
Well, when I was training at the Guildhall, they were contacted by Headway East London. This is a centre for people with acquired brain injury. There were a couple of fellas there who liked to rap together, right? So I thought, well, that sounds interesting. And I used to be a sound engineer, and so I knew a lot about recording and using, drum machines and loops. So I said, I'll do it. So before I qualified, I went and started volunteering there and working with these two fellas. It was very good. It was funny and incredibly creative, and it was lovely to see these two people working together in the way that they did, with all the difficulties that they had, and that they had this kind of shared identity with rap music as well. And I was interested in music and neuroscience anyway, because I'd read a lot of Oliver Sacks and was fascinated about the way he talked about it as a really effective adjunct to pharmacological interventions, and how important it was to have human interventions alongside those, not just music but other ones as well. And his case studies described all of these responses to music making the world coherent and helping life coordination as well as physical coordination. And so I really wanted to go in that direction. And there were no placements on neurorehab centres then, and there are very few now. And I got one day at the Royal Hospital for Neurodisability where I observed, and that was it. So I was really keen to get into that work. And whilst I was volunteering, that extended beyond my qualification in 2004. And so eventually I got a job there as a support worker. And then we raised some funds so I could do 3 hours music therapy a week there as well. And then we got more funding and it became a 2-day post. And we had some instruments loaned to us by Neurorehabilitation Robbins, who were a music therapy charity, and that obviously really helped. And then when I left after about 5 or 6 years, it was handed over to someone else. And now it's developed in all sorts of ways. But that, then I got another job working for Neurorehabilitation Robbins Outreach at Headway in Henley-on-Thames. And then I worked for the local authority as well, a few different ones, but mainly one in Bedfordshire, the Child Development Centre in Kempston. And that was really amazing work as well. I did lots of songwriting with people with cerebral palsy, and it really helped them when they were transitioning from their special school environment to semi-supported living, and I learned a huge amount working with them, and also other children with cerebral palsy who were able to walk a bit, and we sort of used something called rhythmic auditory stimulation to help see if we could improve their walking, and the teachers were fantastic in the school. This was at Ridgeway School. I would sort of set up, this is the music that you use for synchronizing the movements to, and all of the pre-gait exercises and things like that. So yeah, that's sort of how it went on. And then eventually, when I was working at Headways London, before I left, I'd done some training in something called neurologic music therapy, which is essentially another branch of music therapy. It does have some useful models in it for the sort of clinical reasoning why you're doing what you're doing and using music in the way that you are. And I thought, well, I wonder if any of this really works, because a lot of the supporting literature for the different interventions were kind of related. They fed into it, but nobody had actually done much research into, upper limb training, for example. And so that's what I thought, well, I'll do that then. To be honest, at a certain point, what I really wanted to do was train as a psychotherapist, because I was much more interested in the psychoanalytical side of things. They fascinate me a lot more. And a lot of that was because when you train as a music therapist, you have to undergo your own therapy. It's an essential component. And my training was a year. I stayed in therapy for about 3 years, and, because I needed it, not because of the training. And I really benefited from it, and I learned a huge amount. And that's really informed my work. Even if I'm doing functional things with people, I'm still thinking about what they're saying and how they're responding and how to manage that. So anyway, I couldn't train as a psychotherapist because I couldn't afford it. But then these bursaries came up here, and so I thought, well, I'll go for that. And I got the bursary, that paid my fees and gave me a stipend. And that's how I did my PhD.
Following completion of your PhD, which focused on upper limb rehabilitation, you continued your research and in 2019 became a Senior Research Fellow at the Cambridge Institute, where you are now. Now, a Senior Research Fellow is probably one of the more hidden roles in the higher education sector. In addition to progressing your research, what does university working life look like for you in your role?
At the moment, the search for funding has intensified because there's a huge global financial crisis, isn't there? And in every sector, there's a crisis. So, of course, now there's been a real seismic shift in that, before we would get grants, and if they funded our research, then that's great. Whereas now the directive is, and it needs to cover your salary. So that kind of, you sort of think, okay, there's a bit of leeway, because they do understand that, it gradually gets scaled up. And I suppose it's only since about 2023 that I've had tenure as a researcher. So I did 8 years of postdoc and senior research fellow, and then thought, oh, well, that's it. So I'm going to go and look for some more clinical work now. And so I said, right, bye. And they said, what do you mean you're going to? And I said, well, there's no permanent contract, and the funding's run out for this 4-year, Radio Me project. Oh, no, HR will be in touch with you. And I think that's a big thing with university life in terms of all of the different faculties and everything, and knowing people. And it's really hard to find the time to just attend events or even network outside of those events as well as inside them, so that we go, oh, God, there is somebody here who knows how to program and code and make apps. Oh, there is someone else here that knows about stroke rehabilitation. So there's that, and that has improved. Since I got tenure, I suppose I've made a rod for my own back, in that I thought, right, now I've got to do all of the things that I couldn't do in the 4 years that I was doing Radio Me. I've really got to sort of crack on, and so that's why I have the Friday clinic, the musicians group, the app, there's also another music listening project with the Coleman Hospital in Norwich, with the psychologists and physios working there, where we're trying to explore ways of managing fatigue, because it prevents people in subacute rehab from benefiting as much as they can from that really intensive 12 weeks or more of inpatient therapy. I'm supervising PhD students, so some really interesting projects, like sort of community-based amyotrophic lateral sclerosis or motor neuron disease intervention for bulbar function, so that's swallowing and respiration, so to help with breathing, but also the impact it had on mood. And that was done in Moscow by my first PhD student, with great benefits actually for the participants. I mean, it's a neurodegenerative condition, but it really helps them actually improve their swallowing and respiration and speech articulation as well. There are master's students, so I do a little bit of supervision when they go off on their placements as part of their training. I support them as a supervisor, and that's really interesting because I get to see what they're doing and how they're learning. I think that's sort of all of it really, because I am part of a research institute, and which has been running for just coming up for 10 years now. So let's see what happens.
And reflecting on some of the things you've talked about so far, and your approach to music therapy as a practitioner researcher, are you able to share a case study about what your practice looks like in reality?
With the clinic that runs on Fridays, there are a couple of women that come that both have upper limb hemiparesis in differing degrees, and a little bit of aphasia, so sort of word finding in speech and articulation, dyspraxia of speech. And they have brought real insight into why they would come and mess around with musical instruments, and so some of the things that they say, they say they go to a gym, but of course the people at the gym wouldn't understand, why we come here, because it's sort of a bit like therapy, I thought that's one of the added values about using music for stroke rehabilitation, is that it doesn't feel like therapy. So I thought, well, that's great that you said that to your fellow sort of people at the gym, Yeah, and they've talked about the sort of the structure of the music and how they know when to move and how to move, and it really helps to support them. Again, the touchscreen technology we're using as well, which helps the one with less movement be able to activate a sound, and how the music all fits together. So when we did a group with them as well, and that was really interesting, and looking back at the video afterwards as well about how they talked about it. So they were using the instruments in the same way that they needed to improve their activities of daily living, reaching out, picking things up, dressing and self-care and cooking and all of those things. And we were positioning them to facilitate those movements, but they were also composing a piece of music together. So there was a huge cognitive element to it in terms of that executive function, the planning and organising and everything. And they just talked about all of that afterwards when we sat, and they said, yeah, and it seemed to make sense that this was about the journey and the change. And because I didn't even suggest anything, one of them just said, well, I think we should do something about, how things have changed for us. And of course, that then elicited some conversation about how things had changed. And so it did become this sort of sharing experience between these 4 stroke survivors in this space. So it actually encapsulated different approaches. The psychodynamic, it was important that I was a therapist in the room and I could facilitate this, and they felt safe, all the boundaries were there and everything, but also they understood the what it was doing for them cognitively and physically and emotionally as well, because when one of the ladies was playing a violin sound right at the end, when they got to the stage where they were coming to terms with the stroke and the change but still trying to recover, and this violin was playing and I was accompanying on the guitar and the other lady was playing the piano, and she turned around and she was crying, And she said it was because of the sound of the violin. She said it was just the way it was being played and the sound of it that just brought it all up. And then she was laughing and crying at the same time, of course. And that's another important part of the sort of management as a therapist, is that just because someone's crying, it doesn't mean to say something catastrophic has happened. There's always levity, or often there's some levity there, and you can acknowledge it and be receptive to it in a way that is, God, look at you, and I'll be crying soon as well, and it's okay, to do that. So yeah, that I hope anyway exemplifies the kind of thing that can happen, the sort of potential.
Yes, it does, and I guess it also shows how what you're doing combines both the functional physical benefits as well as the more psychodynamic ones. And that combination of models is what your first article was about.
The first article I wrote was exactly about that in 2011. And that was from some of my clinical work, where I was hiring a space. I got them to commission a physio to come in, and we were doing rhythmic auditory stimulation for walking, to improve walking. And we also did songwriting, because he discovered that he really enjoyed doing that, because he discovered his preserved skills. He discovered that he was really quick-witted, very quick-witted. Speech was quite slurry and slowed down, and it prevented him from contacting friends on the phone, and so he became more isolated. But here he discovered his preserved skills, and he could come up with brilliant rhyming couplets. And he was so excited when he did the songwriting that the gait training sort of paled into insignificance. And when he had a sort of 12 centimetre increase in stride length afterwards, he just shrugged his shoulders and said, well, excuse me if I don't jump for joy. But he loved the recording that we'd done of the song. And this was a medico-legal settlement, so it wasn't a stroke. It was from a road traffic collision. And then he carried on doing that for 6-7 years. He may even still be doing it now with another music therapist, doing this songwriting, really expressing himself, telling his story. And that's what it comes down to. Whatever work we're doing, it's the clinical reasoning. There isn't a model that works and it's a one size fits all. It's not the only way of working is neurologic music therapy. No, that's absolute nonsense. And anybody that is trying to sort of put that across doesn't understand what clinical reasoning is.
Looking back at those case studies you just shared with us, and also thinking about your general research, it's obvious that music therapy has a positive impact. But within a UK healthcare environment which is highly challenged, to what extent is music therapy being utilised to those people who could benefit from it, and what more needs to be done?
Helping other allied health professionals as well as service users and caregivers to understand why they should use music therapy. So I go to Stroke Association online meetings, and I present some research and some work that I've done that helps people with their speech and movement and concentration and things like that. and I go to face-to-face events and do that. There needs to be more of that going on. There are other organisations that do organise them. Probably, I don't know, maybe we need to completely restructure the music industry, right? So that it's not all about, image and marketing. It's about understanding the health benefits. And of course, we can all see that there's some sort of branching out. There's some roots growing in that direction. There's some technology that's being developed, like X System, which is a system, an algorithmically driven playlist curation system based on heart rate variability that can help maintain or adjust arousal. Fantastic. I mean, people use music for exercise and those sorts of things. It's such a big picture question, really, because we need to think about music across the lifespan. We need to think about music as part of being a human being. And there's not enough of that going on. And it's easy to skirt around that when money is tight. And money is tight, and it's not going to change. And so I suppose there's going to have to be some growth in the community, lots of altruism, but they've got to be people who are around who are musicians that understand why should I be playing this instrument or singing this song. So, yeah, that's not a very sort of distinct, precise answer. And I don't have the answers. I can demonstrate all of these things, and I love doing those workshops. Wouldn't it be great if there were people doing, going on the road and presenting publicly how all of these things work? And I'm sure, maybe there's some Arts Council England route of funding to do that, with some measurable change. I don't know how that would come about. But through the sort of major kind of media outlets, there needs to be more of an understanding as well. So that's kind of with all patient populations, really, But I mean, for stroke, I was at the UK Stroke Forum last year, which is the biggest, event in the UK for stroke. And one of the discussions towards the end was, why isn't there enough funding for people who've got stroke in social care or research or anywhere? And it's because people don't know what it is. Everyone knows what cancer is, dementia, heart disease, but stroke, people don't know that it's anything to do with the brain and an event that has caused, billions of cells to be killed in different sort of regions and neural networks. And so there's a new campaign, you've probably seen it, for stroke, but it really depends how many people it reaches. So I suppose music therapy or music to help with neurorehabilitation is tiny within an under-recognised patient population. So there's a lot to be done. But in general terms, there's got to be music across the lifespan, really.
We've talked about your research work and the research work of the Institute, but as a senior research fellow, what does your broader research network look like, both within the UK and more broadly across the world?
Well, I think that's something that makes neurorehabilitation research distinct from a lot of other music therapy research. And there'll be other music therapists in those other populations that would pull me up on this, but this is what I think. There are lots of music therapy conferences and things like that, but that's not going to help get the music out to the population. So I only really go to stroke and brain injury forums and conferences, and I try my best, and maybe I'll get a poster presentation every now and again. It will be a bit more of a sort of, oral presentation or a workshop. And I need to be networked in with recruitment sites. So all community strokes, which stroke teams and NHS stroke teams, and they all have disseminated all of the information about the projects I'm doing in Cambridgeshire and Bedfordshire, and also Norfolk and Suffolk. Networking with, well, let's say Queen Square, which is part of UCL, which run probably the most comprehensive upper limb rehabilitation centre in the world. And, Nick Ward, runs that. And Alex Leff is part of the neurorehab group, more to do with speech. So it's constantly trying to maintain networks with these people and also with health tech. companies. So Camgenium is the company in Cambridge that I have been collaborating with for almost 10 years and, trying to get things moving. I mean, of course, you've got to be publishing all of the time. And I'm very sceptical about that. I think that the whole academic publication area is in crisis and it's not going to change. And we need to think, what's going to have more impact and more reach. Podcasts like this, for example, making short films, documentaries, trying to get things much more out there, whether it's through YouTube or more sort of mainstream routes.
What advice would you give to anyone looking to go into the music therapy profession, or maybe an existing music therapist looking to move to work partly or fully in higher education?
I can't help but being stuck in neurorehabilitation, and I don't know how much this applies to other patient populations, but I would say try and think beyond music therapy so that it can become more accessible and equitable for anybody, really. So try and do your research in close collaboration with other allied health professionals that might be able to help with the delivery, and you're creating a workforce in a way, but actually you're increasing their toolbox for what they're doing. So I think that's really important if they're going to go into research, and they must find a good mentor with really good research experience in their field. That's absolutely crucial. And I suppose, if someone wants to get into research, I don't know, maybe there's a way of getting some research as a research assistant before going into something like a PhD. But it is all consuming. It's, 7 days a week, a lot of the time doing a PhD.
And finishing up our conversation, what's your top focus for you, for your practice and or your research in the next 6 to 12 months?
Well, my practice is quite limited because of time constraints. But if I were to have a caseload again, I would be focusing a lot more on helping with home programs, which I've always done previously. So that for neurorehabilitation, dosage is absolutely key. So the number of repetitions of everything that they do is the only way that the brain and nervous system is going to change and become, more effective and enable them to be more independent. But with the research, the app is really, really key, because that is going to be a route into patient benefit. I'm only interested in patient benefit. I only got into research as an applied researcher.
Alex, it's been really interesting talking to you today and hearing about your work. Thank you very much for being my guest.
Thank you very much, Susanna. It's really good to see you again.
The Association of Higher Education Professionals and the British University's Finance Directors Group, BUFDG, are both proud to support job shadowing HE as a valuable source of professional insight. The podcast was presented by Susanna Marsden, and you can find out more about her consultancy work at susannamarsden.co.uk. Audio production and music was by me, Rodri Marsden. Find out more about this podcast and hear previous episodes at jobshadowinghe.com.